Hi, welcome to this session of surgery recall. The questions of the surgery asked in the like yesterday's uh, FMGE exam. Okay, so there were approximately I got maybe like 40 questions of surgery. Okay, so let's discuss these questions and if you see if like if any of the options or the question is I mean if you remember it differently, then please let me know so that I can update it. Okay, this is as per like asking the students like who have given the exam. I have recollected these questions. Okay, so let's start with the first question. There were like 40 of these questions. Which of the following is the current sequence of damage control surgery? So in the damage control surgery, we'll do when the patient comes in the trauma triad of death, hypothermia, acidosis, and coagulopathy. So first thing you need to do is identify which patient needs damage control surgery. Okay, if the patient comes with trauma triad of death. Then second thing is you need to do the abbreviated laparotomy. Okay, abbreviated laparotomy to control the bleeding, to limit the contamination. And then leave the abdomen open or do some temporary closure and send the patient to ICU for the further thing. And then you will take the patient again in the next 48 hours and do the definitive repair. Okay, so I'll write fourth is the definitive surgery, and if possible you can close the abdomen. If it is not possible, then the abdominal closure can be done later on. So this is like the sequence. So I guess that was the question. Okay, so first, then comes third, then comes fourth, then comes the second, and finally the abdominal wall closure. Okay, so this should be the answer. Okay, good evening. Okay. Okay, next question. Which of the following is affected in the disease shown? So there was an image shown of the varicose vein, and the varicosities were seen in the medial aspect of the leg. That was going, I guess, till the thigh. So this is the area where the great saphenous vein goes. So this is in the territory of the great saphenous vein. Short saphenous vein will be seen lateral. Femoral vein, you will not see the varicosity. Okay, femoral vein is a deep system. You will not see the varicosity in the femoral vein. Perforators can give the small varicosities in the area where the perforators are present, at the ankle, at the lower leg below knee level. So this is very straightforward. Great saphenous vein. Yes. Next question, there was a question again image based, and they had asked identify the pathology. There was a swelling arising at the umbilicus, and looking at this, it was, I don't think anybody did mistake in this. This is very classical umbilical hernia. Inguinal hernia will be seen. See, when we talk about the hernia, see, this is the area where you will see the umbilical hernia. This is the area where you will see the inguinal hernia. Femoral hernia is seen below and lateral to pubic tubercle. So maybe here you will see the femoral hernia. And Spegelian hernia you will see at the lateral border of rectus, just above the arcuate line. So somewhere here is the site of Spegelian hernia. Okay, so that was very straightforward umbilical hernia given in the picture. Next question, a patient with gastroesophageal reflux disease has a nodule in the second part of the duodenum. Which hormone level to be measured? Okay, so now this was like kind of an indirect question. In the second part of duodenum, okay, this part. So which tumor can be seen in this part? Okay, we know that there is a triangle known as gastrinoma triangle or Passaro triangle, the junction of cystic duct and the CBD, junction of second and third and fourth part of duodenum and junction, second and third part of duodenum and junction of neck and body. So if you join these three things, you will see this triangle. Okay, so this is gastrinoma, and which other thing goes in the favor of gastrinoma? Paraumbilical hernia जैसा कोई term नहीं. Sushil, now there is no term like paraumbilical hernia. Okay, the European Hernia Society says it is umbilical. There is nothing like paraumbilical. Paraumbilical hernia term has been removed. Okay, so you can consider this was umbilical hernia. Okay, previously they said that if it is not arising from the umbilicals but anywhere like either right, left, up or down, then it is paraumbilical, but that term has been removed. Now it is umbilical hernia only. Okay, so patient is also having gastroesophageal reflux disease. Okay, so this gastrinoma causes increased gastrin production, and because of increased gastrin there is increased HCl, and that can lead to this gastroesophageal reflux disease. Gastrinoma patient can also have diarrhea, they can have this refractory peptic ulcer disease or atypical peptic ulcer disease. Okay, any confusion in this? Again, a very easy question. Irregular edges, shallow base, pigmentation. So a ulcer in this typical site of the gaiters area, lower 1/3 of the leg, medial aspect, shallow sloping edge. This is venous ulcer. This is venous ulcer. Okay, this is venous ulcer. Trophic ulcer you will see on the plantar side. Plantar aspect, ischemic ulcer, arterial ulcer on the dorsum of foot or in the tip of toes or in the web spaces. Infectious ulcer, as such there is no ulcer known as infectious ulcer. Any ulcer, if they develop infection, they can be infectious. Okay, so looking at the site, this is very typical venous ulcer. Okay, a patient has tumor in his left lobe, a left hepatectomy is planned. What segments to be resected? See, Coinod had divided the liver into 8 segments, 2, 3, this is 4A, 4B, 5, 6, 7, 8. Segment 1 is somewhere posteriorly. Segment 1 is somewhere here, posteriorly 1. Okay, so this segment 5, 6, 7, 8 is a right hemiliver, and segment 2, 3, 4 is the left hemiliver. Segment 1 is going on both the sides, so segment 1 we don't put on either side, it is common to both. Okay, so if there is left hepatectomy done, then we'll remove segment 2, 3 and 4. Segment 2, 3 and 4 is removed. 5, 6, 7, 8 is the right hepatectomy. Right hepatectomy. Okay, this was also okay, not a problem. Now there was an image of breast given where there was skin dimpling. Dimpling of the skin is shown. What is the reason of skin dimpling in case of carcinoma breast? Lactiferous duct involvement will lead to nipple retraction. Dermal lymphatics will lead to orange appearance. It is the Cooper's ligament involvement of that leads to dimpling of the skin. Yes, Cooper's ligament. Yes, Cooper's ligament. Okay. Now this question. A patient underwent laparoscopic cholecystectomy 4 days back. Now the patient is having pain in the right upper quadrant and ultrasound shows collection. See, when you do a laparoscopic cholecystectomy, like there will be clip-on cystic duct. So suppose there is an injury. I mean, whether there is injury to the common hepatic duct, CBD, or suppose this clip has dislodged. Now what will happen? There will be bile coming in this area. So because of this bile, patient can have pain, patient can have jaundice, patient can have fever. But already 4 days have passed. If this injury is identified at the time of doing laparoscopic cholecystectomy, then you can do the repair, either primary repair or hepatococcygeostomy or putting a T-tube or end-to-end anastomosis. But after 4 days are passed, now even if there is, I mean, you know that there is injury, you cannot do anything at that time. So what best you can do is, the first thing is drain this bile, because this is acting as a source of infection. So you can do a percutaneous drainage. You can put a catheter, pigtail catheter or a tube under the guidance of ultrasound or CT. So now the collection will come in this part. Now the collection will come in this part. See, somebody said that in that umbilical thing there was a swelling around the umbilicus. So umbilical hernia, paraumbilical hernia, that is the same thing. Okay, now there is no difference between umbilical and paraumbilical. Don't worry about it. So percutaneous drainage of the bile is the first thing. After that, you get the MRCP to see that where is the injury, what is the extent of the injury, and after that do a delayed repair. Do a delayed repair in the form of hepaticojejunostomy. Only if the injury is like Strasbourg A type of injury, where the bile is coming from the cystic duct, in those cases you can do ERCP and stenting, and mostly the bile stops coming. But apart from that, any major duct injury, it is hepaticojejunostomy, which you will do later on. Okay, so the answer is ultrasound guided percutaneous drainage of the collection. Next question, a 2-year-old kid had a scrotal swelling since birth. Now, scrotal swelling since birth, there are two possibilities: congenital hernia or hydrocele. Now there is a painful red irreducible thing. So if it is irreducible, means there is something which has come in that area and now it is not going back, so it has to be hernia. And it is red, it is painful, it is strangulated hernia. It is strangulated hernia. Okay, in epididymoarthritis generally does not occur in that young age group, like 2 years, but even if it is there, there will not be anything related to the swelling since birth. So this is gone. Torsion testis, again this is not the age, and the second thing is there will be no swelling since birth. Hydrocele could be the possibility, but hydrocele does not present with painful red or irreducible swelling. Okay, so that's why the answer is strangulated hernia, a congenital strangulated hernia. That's why there is recommendation that if there is a congenital hernia, it should be repaired as soon as possible because of the risk of strangulation. Congenital hydrocele, you can wait and watch till 2 years, and if it persists beyond 2 years, then you need to go for repair. And by repair I mean herniotomy. Herniotomy is the surgery for both congenital hydrocele and hernia, because the basic pathology is patent processus vaginalis. Next question, there was a suturing technique given in the image form. It might not be the same image, but you can see there is a suture, then there is a knot, then there is a suture, there is knot, and the suture is crossing that midline edge. So this is a simple interrupted suture. Simple interrupted suture. In subcuticular suturing, you will not see any knot. Okay, there is because one knot at the beginning, another knot at the end. You will not see the thread in between. In the vertical mattress suture, suppose you are doing the vertical mattress suture, you will see something like this on one side, and there will be a knot on other side, like this, and knot. So that is vertical mattress. You will not see the thread going in the midline. And horizontal mattress suture will appear like this. The thread is going like this, and then there is a knot. Thread is going like this, and then there is a knot. So this is how the horizontal mattress suture will appear. This was the image of a simple interrupted suture. Simple interrupted suture. Next question, the patient was diagnosed with 8 cm chylomlymphatic cyst. There are two types. Chylomlymphatic is a type of mesenteric cyst. There are two types, chylomlymphatic and another is enterogenous. Now see, chylomlymphatic is, suppose this is the bowel and this is the mesentery. So in the mesentery there is a cyst which is separate from the bowel. This is chylomlymphatic. And enterogenous is This is a cyst which is sharing the common blood supply with the intestine. So in this case, you can remove the cyst without removing the intestine, but in this case you have to take this part of the intestine from where it is arising. Okay, so because it is chylolymphatic, so just removal of the cyst is good enough, that is enucleation. Suppose it was enterogenous, then you have to, this is the treatment for enterogenous. Resection of the cyst with the adjacent bowel. Aspiration will definitely cause recurrence. Conservative treatment is not recommended. There is a triad seen in chylolymphatics, I mean all these mesenterics, that is known as Stillok's triad. Okay, so simple enucleation is good enough. Next question, a neonate has intestine protruding from the abdominal wall without covering. So without covering, a abdominal wall defect, congenital, mostly just to the right of the umbilicus, and the intestines are hanging out without any covering. This is known as gastroschisis. Another defect in which, that is at the level of umbilicus, the umbilicus is usually absent and there is a thin membrane covering the defect, and this is known as omphalocele. Omphalocele. Okay, so what is the next step? See, the main thing is, if the bowel keeps on hanging, then there are high chances of necrosis, ischemia. So first thing is, you need to cover the bowel with a silo, and you can wait, you can, the silo is there. So if you gradually start twisting the silo, then it will gradually push the intestine back into the abdomen, and this is what has to be done. So the first step is put the intestine back in the abdomen, and after it is inside, then you can do the closure. Either you can do the closure or you let it heal by the secondary intention, and later on when the child becomes like maybe in the childhood period, you can do the repair like you do repair of the incisional hernia. Okay, so initial step is cover with silo and wait. Cover with saline and shift to ICU. See, shifting to ICU is, yes, it is better if you put the patient in ICU, because these anomalies like gastroschisis, omphalocele, they can have other associated things also. I mean, that thing is more common in omphalocele, so you need to rule out other associated congenital anomalies. But if there was an option of cover with silo and there is this thing cover with saline and shift to ICU, then I guess covering with silo is a better option. If there was something like cover with silo, then it is a better option. Immediate repair is as such not required. Or if silo was not in the option, then yes, cover. Okay, let's say cover with saline. I mean, you should cover with saline means a moist gauze, and then you can shift to ICU, and in ICU you can put a silo. Silo is just a transparent type of bag which you put, like suppose this is the defect, this is the intestine hanging out. Okay, so you will put a kind of plastic covering, because it is not covered by anything, like this. Okay, just a plastic covering. And just imagine when you rotate it, it will gradually try to push the bowel inside. It will push the bowel inside. Okay, so that is silo. That is kind of a plastic bag which is used to, keep the bowel inside a kind of membrane, so that otherwise if it is hanging outside, there will be lots of heat loss, it will become dry, it will become injured. So you can put it a silo and then you can push it back. Okay, if silo was not in the option, cover with the saline moist gauze and then you shift the patient to the ICU. That is the better answer. Okay. Next, there was a question with child with 20% or maybe 22% burn, low urine output after 6 hours, and the urine output is 0.3 ml per kg per hour with cool extremities. See, in the kids, when you are giving IV fluid, obviously IV fluid is required for more than 10% burn. Patient is having 20%, so this kid definitely needs IV fluid therapy. So when you are giving, the goal of urine output in pediatric patient should be more than 1 ml per kg per hour. And this kid is having 0.3 ml per kg per hour. Definitely it is less. So for that, and cool extremities means the child is already in a kind of shock. Shock means hypovolemic shock. This is what you get in burn patient. Okay, so what we do in these cases is give IV fluid, give a bolus because the patient is in hypovolemic shock. So you give the fluid and then increase your fluid flow because you are not giving enough, and that is why the child is going into hypovolemia. Okay, if you should not continue with the same rate. Colloids has no role in the initial 24 to 48 hours, 24 to 30 hours. So colloid, if at all colloid is required in the burn patient, that is given from the second day, not on the first day. Waiting for 2 hours will definitely keep the patient, make the child more worse, and the child might not survive also. Okay, so if the patient is having shock, you deal it like a shock, give the bolus of fluid. Okay, I don't know the exact language, but there was a penetrating chest trauma with tracheal deviation. If you remember, please let me know that whether anything was given for the BP or heart rate in this. Penetrating chest trauma, tracheal deviation. So there is tracheal deviation, means it could be hemothorax, massive hemothorax, or it could be pneumothorax. Now we don't know. I am very sure that there must be something else also in the question, because if you look at this question, this is absolutely incomplete question. So there must be something. Okay, maybe hyperresonant note, maybe hypotension. Because if there is hypotension, tracheal deviation, now it is going in favor of tension pneumothorax. Now it is going in favor of tension pneumothorax, and then needle decompression is the better answer. Now the needle decompression is the better answer. Okay, one option was E fast. So okay, let's say we'll say E fast here. But I am saying, I am very sure there should be something else. Okay, because at this moment we cannot say it is or massive hemothorax or pneumothorax. Anything can, even hydropneumothorax, Gaurav, yes, also can lead to this problem. So there should be something else, but looking at yesterday also I talked about these questions and people were saying that they did not find any problem. There was needle decompression was the best answer. So there must be something else also in this question. If there is hypotension, then yes, there is tension pneumothorax, and needle decompression should be the first thing. Put the needle in the 5th intercostal space mid-axillary line, and after that you can put a ICD in the same area. Okay, there was a question about there was some severe head injury, the GCS was poor, and the CT is normal, and the patient died in the next few hours. What is the likely injury? See, EDH, SDH, there is definite CT images. Okay, concavo-convex hyperdensity, biconvex hyperdensity. Brainstem contusion. Contusion generally is not that severe an injury, but yes, diffuse axonal injury is fitting in the picture. Diffuse axonal injury can be the answer, because in diffuse axonal injury the CT is normal. For this, MRI is the investigation of choice. CT might appear normal, MRI will give small punctate opacity. Retraction ball was given in the question. Which question? Study point MBBS. Which question they had given retraction ball? Okay, so diffuse axonal injury seem to be the better answer. See, the options are not exactly how it was there in the question. Okay, the option was option can be jumbled. So if you remember that, okay, I have marked C for that or B for that, don't go for it. Okay, the options can not be same or in the same order as it came in the exam. So just see that, we are talking about the topic. Okay, this question we'll discuss. Okay, Dr. Madhan will discuss this question. 14-year-old with acute testicular pain, absent cremastic reflex. This is a very classical, the age group, the pain and absent cremastic reflex. There is no point in knowing that it is torsion of testis. Okay, it is absolutely easy to make the diagnosis, torsion of testis. Now, what will you do in this case? Torsion of testis is a condition where the testis rotates around the somatic cord in which the testicular artery comes. So you don't have too much of time. Within 6 hours, you should do the surgery. Otherwise, after that, if you open, you will see a black testis because of the gangrene. Okay, so wait and watch is absolutely not there. Antibiotic has no role. Doppler you can do, but it's not venous Doppler. If at all any Doppler has to be done, it should be arterial Doppler, which will show that whether any arterial flow is there in testis or not. But even if the Doppler is, you should not wait for the Doppler report to come. Okay, torsion of testis is a clinical diagnosis. If you think it is torsion, don't waste time in running for the Doppler. Just take the person in the OT and open up the scrotum to see the testicular condition. And if it is healthy, then you do orchidopexy on both the side after detorsion. But if this testis is gangrenous, you remove this testis, but do the orchidopexy of the other side, because that is also referring to a higher center will be a very, very this is something which might land you up in the court of law for the negligence. Okay, so refer to the higher center. Maybe if you are sitting in a dispensary, then where there is no surgical facility is appropriate, but if you are in the hospital referring this to some other thing, definitely the patient is going to lose one ball. Okay, so that should not be done. Explore. Okay, after maxillofacial trauma, cannot intubate or ventilate. Okay, so maxillofacial trauma is we have discussed in the trauma classes that this is one of the scenarios where at times it is very difficult to do the intubation. Okay, because of the fractures, because of the problem restriction in the mobility, and there could be bleeding significant enough, so you might not be able to see the vocal cords to intubate. And airway obstruction is something where you cannot take too much of time. If you cannot do this, cannot intubate, cannot ventilate, go for a surgical airway. Now these two are the surgical airway, cricothyroidotomy or tracheostomy. And like I said, if arterial Doppler is also present and the patient has come within 1 hour, okay, mask. If the patient has come within 1 hour, so you can go for that. Suppose they say that patient has come at 5 hours later or 6 hours later. Even if the Doppler is present, you take the patient to the OT, because the patient has come at the very, you can say that time is at the edge of the time, and if you delay time in Doppler, again the patient is going to lose the testis. So even if Doppler is there, if the patient has come early and Doppler is readily available, go for Doppler to confirm. Otherwise you explore. Okay, what will happen? There will be like maximum what can happen, acute epididymoorchitis is there. So when you open up the testis, when you open up the scrotum, you will find that okay, there is no torsion. So there will be a scar on the scrotum that is also not seen. Okay, it's not that scrotal scar is going to cause some cosmetic disturbance in that person. So opening it up is always a better option. Even if you are wrong after opening, nobody is going to hang you for this. But if you think that it is epididymoorchitis and you wait for the Doppler to come, and after the Doppler, when you open up and the testis is gangrenous, like I said, that could be a medico-legal issue. So among cricothyroidotomy and tracheostomy, cricothyroidotomy is the better option because this can be done earliest. I mean, you can do this in seconds. Okay, you will do this in seconds. Okay. Okay, next. And even if like somebody is saying remote health setting, see this opening up of the scrotum does not require a general anesthesia or a spinal anesthesia. I mean, if you have the basic knowledge, I mean, if you can give a local anesthesia in the cord and you can open, even in the remote health setting, you can do this provided a qualified doctor is sitting there, not a quack. And I mean, mostly these days we see in those health center and all, doctors are absent. They are either studying for PG or they are relaxing at home. So if the doctor is there, even at the poorest of the scenarios, because this exploration is done under local anesthesia, one can do it. Anyways, coming to the next question. So here cricothyroidotomy is the better answer. Okay, then there was a question, maybe a long question, but the important points were there was hematomatous polyp in the intestine. Because of that, abdominal pain can occur due to intussusception. And there was melanosis or the lip pigmentation. So all of you know that it is very classical for Peutz-Jeghers syndrome. Peutz-Jeghers syndrome, multiple hematomatous polyp, pigmentation around the lips. So C is the answer. FAP syndrome, there will be multiple adenomatous polyp in the colon. HNPCC can have again the variable presentation. There can be polyp, there can be cancer. And juvenile polyposis is not this classical, that is a rare condition. Okay, remote health setting was definitely in the question, then definitely the answer should be, exploration, because in the remote health setting you will get a doctor, but I don't think you will get a Doppler there. Okay, Doppler in the remote health setting is like finding water on Mars. I mean, you might get, but nobody is sure about it. So, okay, Peutz-Jeghers syndrome. In the following IVP image, what is the diagnosis? So, this is IVP, this part is the kidney, this is ureter, and if you see at the terminal end of the ureter, you can see the dilatation of the terminal ureter, cobra head, adder head appearance. Probably the easiest question, everybody has done it correct, it is ureterocele. In the bladder diverticulum, first of all, IVPV is not a good modality to bladder diverticulum. You can see something like this on a cystogram. Ectopic ureter, you will see that suppose this is the area where the ureter, where the bladder is present. This ureter will be going somewhere down there in the urethra. Vesicoureteric reflux, again IVP is not the good modality. You will go for micturating cystoureterogram or vesicocystoureterogram. Gustatory setting after parotidectomy, everybody knows this is Fraze syndrome because of the injury to, I don't know whether they have asked, whether the question was in Fraze syndrome which nerve is involved, or whether simply they have asked about what is this Fraze syndrome. It is because of injury to auriculotemporal nerve. Auriculotemporal nerve. Okay. Next question. Again, there was some confusion. People were getting confused. After 5 bags of packed RBCs transfusion, what electrolyte abnormality can be seen? So, in cases of massive blood transfusion, okay, to massive blood transfusion, there are different, definition. The most acceptable is more than or equal to patient's own blood volume in 24 hours. But if somebody transfuses more than 4 units of packed RBCs in 1 hour, that is also massive blood transfusion. So, what electrolyte abnormality you can see? First of all, talking about this, you will see hypothermia, not hyperthermia. There can be fluid overload. There can be dilutional coagulopathy. Now, in the stored blood, okay, stored blood, they use the anticoagulant CPD, citrate phosphate dextrose, and that CPD causes hypocalcemia, hypomagnesemia. Now, in the stored blood, the RBCs, they lyse, and from the lysing of the RBC, there will be hyperkalemia. Potassium comes out, so there will be hyperkalemia. There can be metabolic alkalosis or acidosis can also be seen, although alkalosis is more common. Okay, so these are some of the important things you will see. So definitely the answer should be hypocalcemia. Hypocalcememia or if hyperkalemia was there in the option, I guess some of the students were saying that hyperkalemia was not there. Okay, so that's why hypocalcemia. Okay, this was the question you were saying. A child comes after the train accident with stable vitals but a big laceration on the leg. Big laceration. Okay, so if the vitals are stable, definitely patient is not going in the red category, and at the same time the patient is not going in the black category as well. Now there is yellow and green. Now suppose the question was saying there is a small laceration, then it would have been green. But because it is saying big, so in the big laceration, although there is no immediate threat to the life, but big laceration, there are high chances of nerve injury, there are high chances of the tendon injury. So this patient definitely needs hospitalization for the further evaluation. That's why the category will be yellow. So those who have marked yellow, that is the correct if this was the question, yellow. Okay, patient with headache, palpitations, sweating, serum metanephrines are high. I don't think there is any problem in diagnosing that this is a pheochromocytoma. Pheochromocytoma. Okay, pheochromocytoma. Burn, even if it is 25% burn, okay, I guess there are two questions. So see, 20 to 60% burn again goes in yellow. Less than 20% goes in green. More than 60% goes in black when we talk about the triage. Okay, so pheochromocytoma for this question, very classical headache palpitation. Identify the imaging modality. Okay, in multiple times in the class you have seen these images. This one is the craniocaudal view, where you can see the axilla is the mediolateral oblique view. These are the views of mammography. Okay, so mammography, on the simple X-ray you will not see anything. Ultrasound breast will be like hypoechoic, hyperechoic, these images. CT scan is altogether a different image. So this is without any doubt mammography. Okay, patient presents with weight gain, dry skin, features suggestive of Hashimoto. Weight gain and dry skin are the features of hypothyroidism. Which autoantibody is seen in Hashimoto? Very classical, it is thyroid peroxidase. Although this and this is also seen, but thyroid peroxidase is seen in thyroid peroxidase is the classically more than 90% of the Hashimoto you will see thyroid peroxidase. 40 questions from ophthalmology is like, yes, I'll try to give you the PDF of this, and when I'm giving you the PDF in that group on the Telegram, please if you find anything, I mean any language or any option which can be better, just let me know so that I can upgrade it. Okay, mutation of which of the following gene is most commonly associated with the thyroid cancer in which calcitonin is raised? So calcitonin is raised in which thyroid cancer? Medullary thyroid cancer. And medullary thyroid cancer, which gene is where? Ret gene. RAS is for follicular thyroid cancer, BRAF is for papillary thyroid cancer, P53 is for anaplastic thyroid cancer. Calcitonin is high, so it is medullary thyroid cancer. Okay. Which drug is used in the preparation of pheochromocytoma? It is phenoxybenzamine, which is an alpha blocker. You start it as 20 milligram per day and increase 10 mg daily till you get a dose of 100 to 160 milligram. Okay, now you must be thinking that propranolol is also used. I am saying it is also used, but phenoxybenzamine you have to give, and after the alpha blockade is complete by the by knowing that there is postural hypotension, propranolol is plus minus. I mean, if the patient is having tachycardia, palpitations, then you can give. Otherwise, beta blockers are not necessary in all the cases, but yes, phenoxybenzamine you have to give in all the cases. Which of the following is the best treatment for bleeding esophageal varices? Okay, when the patient comes with bleeding of the esophageal varices, just let me know if there is any other option. Okay, so the patient present with hematemesis. So the first thing is you do the resuscitation, give IV fluid, call for blood, and give injection octreotide to decrease the portal pressure. But the best treatment to control is you do the endoscopy and endoscopic put a band there, rubber band ligation, also known as endoscopic variceal ligation. Sclerotherapy can also be done at the same time, but among sclerotherapy and band ligation is better. Shunt surgery these days are rarely done. That is in one of the last resort. Amoxicillin, antibiotic may be given, but it is not going to stop the bleeding. So the best thing which can stop the bleeding is do endoscopy, identify the varices which is bleeding, and put a band at the base. The bleeding will stop. In the Barrett's esophagus, which of the following changes are seen? So in the Barrett's esophagus, that is mainly because of GERD in the lower end of the esophagus, where the mucosa is normally squamous epithelium. Now because of the acid, this starts changing to the intestinal columnar epithelium, and you will see the goblet cells if you do the biopsy. Okay, IV antibiotic, okay, you are saying it is not oral, it is IV. Even if it is IV antibiotic, it is not the answer. Okay, so goblet cells is seen when you do the biopsy. It is a risk factor for adenocarcinoma of esophagus, adenocarcinoma of the esophagus. Okay. Next question. In a patient, fishbone is stuck at T4 vertebral level, most likely site of obstruction. See, when we talk about the normal constrictions of the esophagus, we start measuring from the upper incisor at 15 centimeter cricopharyngeal sphincter, then at 25 centimeter aorta or left mainstem bronchus, and at 40 centimeter when it enters at the diaphragm. Now this 25 centimeter is said because aorta actually comes at 22.5 centimeter and left mainstem bronchus comes at 27.5 centimeter. But because they were very close, so that's why generally it is written at 25 centimeter. You will see aorta and mainstem bronchus. Okay, but if you see exactly, this is the distance. And if you see at the T4 vertebral level, what is the distance from the incisor? It is 22.5 centimeters. So that's why aorta is the answer. Aorta is the answer. From the incisor, the T4 vertebral level will come. If you do the endoscopy, 22.5 centimeters. Okay, aorta. HNPCC, which is also known as Lynch syndrome, is caused by which gene? It is the mismatch repair gene. Mismatch repair, there are lots of genes, like 6 to 7 genes are there, but the most common one is MLH1, MSH2. There is MSH6 also, there is PMS1, PMS2, but these are the two common genes. MSH2 is present on chromosome 2, MLH1 is present on chromosome 3. Okay, so these are the genes. APC gene you will see in the FAP syndrome. You will see in the FAP syndrome. Mismatch repair gene. Patient with hypertension, a visual disturbance, cerebral hemangioblastoma, renal mass. All these things are going in favor of von Hippel-Lindau syndrome, VHL syndrome. Which chromosomal abnormality is associated? We all know it is on chromosome 3. Chromosome 3 is what is involved in von Hippel-Lindau syndrome. Identify the image. I guess this something like this was given, where you can see the pelvic calyceal system, you can see the ureter. This is the pelvic calyceal system in the kidney. This is ureter. This is the urinary bladder. So this you will see in cases of intravenous pyelogram. In the micturating cystourethrogram, a dye is given from here, and then you ask the child or the patient to micturate, and normally you will see only the bladder and the urethra, but if there is vesico-ureteric reflux, then you might see the dye is going higher up with the dilated ureter or the dilated pelvic calyceal system. X-ray KUV you will not see any of the thing unless there is a stone. Retrograde urethrogram will show you urethra and the bladder. It will not show you the kidneys or the ureter. So that's why IVP is the answer. Now, patient after skin grafting for the burn, 4th day after the surgery. Generally, on the 3rd day, we open up the dressing, and it is the very next day, very early stage. There is thickening of the graft at the joint. So, thickening of the graft at the joint means now if you don't do anything, the patient is going to develop a formal stricture or contracture, okay, contracture formation. And if there is contracture formation, then you have to go for surgery and grafting again, or maybe you need to put a flap. But because it is a very early stage, so you can prevent contracture formation. Okay, so your goal is to prevent contracture formation by doing physiotherapy. Okay, patient has to do the active movement, passive movement. Keeping the joint in flexion will definitely cause contracture formation. No treatment required, there will be contracture formation. Excision is at this point of time will be too early. Why not micturating cystourethrogram? Because in micturating cystourethrogram, see, in normal micturating cystourethrogram, in normal, you will see only the bladder and the urethra. You will not see any dye going up. Now, if the dye is going up, means there is vesicoureteric reflux. And in vesicoureteric reflux, many times you will see the ureter is dilated, the pelvic calyceal system is dilated. Okay, so that's why it is not micturating cystourethrogram. You can see the things are non-dilated, absolutely okay, very thin. So it is a non-dilated system, and they have not mentioned that after filling the bladder, this investigation was done. So that's why it is IVP. Okay, patient of RTA with head injury with severe headache. CT was also given, and CT shows this blood in the around the ventricle in the sylvian fissure, and this is the typical feature of subarachnoid hemorrhage. In traumatic intracerebral hemorrhage, you will see the blood in this part. And this is what you see in traumatic intracerebral hemorrhage. In EDH, I am sure you know, you will get a biconvex type of opacity. In SDH, you will see a concavo-convex type of opacity. Okay, so this is the image showing subarachnoid hemorrhage. Which organism is responsible for gas gangrene? I guess one of the easiest questions, Clostridium perfringens, gas gangrene. There is involvement of the muscle. There is air inside the muscle. Crepitus is felt. A very dangerous condition. You should give antibiotic, anti-gas gangrene serum, hyperbaric oxygen therapy, and in certain cases you might have to do amputation. Okay, I guess there were two questions on the blast. I guess there was one question that in the blast, which is the most common organ or area injured. But let's see this question. Just let me know in the comment that whether there was one question on the blast like this, or there were two questions. After a blast, the building fell and caused crush injury of the leg. This comes under which type of blast injury? See, primary blast injury is because of the pressure. Because of the over pressure, the air expands and there can be injury to the tympanic membrane, lung, intestine. Secondary is all the penetrating injury comes under this. Tertiary is the blunt injuries or the amputations comes under this. And quaternary is because of the burn. Okay, so this question typically says that it was a tertiary type of injury. Tertiary. Okay, there were two questions on the blast. Okay, so one more question, let's say. This was the question in the blast, which is the most common. In the blast, most common organ or area injured. I guess tympanic membrane was there in the option. Tympanic membrane or the middle ear. I mean, usually when the building falls and crush injury occurs, it is blunt injury. Okay, Prerna, I mean, if you're saying it was there in the penetrating injury, penetrating injury does not cause is crush injury. So either there was crush or there was penetrating, because crush is typically blunt injury. Okay, no penetrating injury causes crush. So either crush was not there or penetrating was not there. Both cannot be there. So I mean, you had given the exam, so probably you are knowing better. But I don't think that both penetrating and crush go side by side. Opera singer after the larynx surgery can't hit high notes. Which nerve is involved? So can't hit high notes because tensor of the vocal cord, that is cricothyroid, is gone, and that is supplied by external laryngeal nerve. Okay, superior laryngeal nerve gives two branches: internal laryngeal, external laryngeal. External laryngeal supplies cricothyroid, and the internal laryngeal supplies the sensory part of the larynx above the vocal cords. Below the vocal cords, the sensory as well as motor is supplied by recurrent laryngeal nerve. Which vein is involved in the esophageal varices? See, esophageal varices are the area where there is junction of the portosystemic anastomosis. Portosystemic anastomosis. Okay, so here the portal component of the vein is the left gastric vein. So left gastric vein is the answer. Left gastric vein is the answer. Yes. Okay, so I guess these were the questions. If you remember any other question of the surgery apart from those which we have discussed, please let me know. And on that group which we have created on the Telegram, if you remember any other question which is related to surgery, there may be one or two more questions where maybe anatomy sir has discussed, or radiology sir will discuss, or maybe I mean in surgery there is a little bit of overlap is there. But if you think that there was any other surgery question which I have not discussed, please let me know and we'll discuss those questions later. Okay, so thank you very much, and I wish you all the very best for the exam. These were the questions which were doable, and I guess out of this 40, if you have read nicely, 30 plus, 35 plus, you can easily mark. I mean, there are silly mistakes, but yes, I'm very, very hopeful that you will pass with very good marks, and we'll meet again in that, celebratory session. Thank you very